Hi guys, this is Zoheb, and I'm one of the junior doctors in the United Lincolnshire Hospitals Trust. I wanted to do a quick run through on common urological malignancies for medical students that you're likely to encounter in the wards. We'll be covering BPH and prostate cancer, bladder, renal, and testicular cancer. And to make things a little easier to read through later, I've tried to fit everything you need to know at the medical student/F1 level into one page for each of these diseases. So hopefully that helps. So let's start off with benign prostatic hyperplasia. So obviously from the name benign, this isn't technically a malignancy, but it's good to know about it just for context on learning prostate cancer, which we're going to go through next. So in terms of definition, the prostate is a testosterone-sensitive organ. And this means that in this organ, you've got conversion of testosterone to the more potent DHT. And this happens via the enzyme 5-alpha reductase. So DHT causes the overproduction of cells in the prostate, usually the stromal cells and the glandular cells, without tissue invasion or malignant morphology for it to be benign prostatic hyperplasia. So in terms of the typical presentation, risk factors include age, African/Caribbean ethnicity, family history, and obesity. You can see in this picture how an enlarged prostate literally constricts the urethra. This causes backflow of urine, which causes lower urinary tract symptoms. And lower urinary tract symptoms can be divided into storage and voiding symptoms. Storage symptoms include urgency and frequency, whereas voiding symptoms include incomplete emptying, weak flow, and terminal dribbling. On examination, patients might have a palpable bladder from retaining all that urine, but a DRE is essential for diagnosing BPH. You'll feel a soft, smooth, and symmetrical prostate on DRE. So when thinking about differentials, it's always good to structure it into secondary differentials and red flag differentials. We can then use our differentials to guide our investigations moving forward. So for BPH, the secondary differentials could be a UTI or an overactive bladder, whereas our red flag differentials to look out for are prostate cancer and acute urinary retention. So how do we work up BPH? We can structure our investigations into history and exam, bedside tests, imaging, and other tests. Think of it almost like going from least expensive to most expensive. For history and exam, like I said, DRE is essential in BPH. For bedside tests, we need to look at PSA, or prostate-specific antigen. So the normal ranges for this molecule depend on the patient's age, but in general, PSA less than 10 nanograms per deciliter means low risk of prostate cancer, 10 to 20 is intermediate risk, and over 20 is a high risk. The thing to know about PSA, though, is that it has a high false positive rate, which means it might scare you into thinking that there's a malignancy when there isn't really one going on. We'll go through some other causes of raised PSA later. So other bedside tests to do is a urine dip to rule out UTI, and then your routine FBC, CRP, urea, and electrolytes. For imaging, you want to do an abdominal and bladder ultrasound. In BPH, you'll see a prostate gland that's more than 30 milliliters in volume. You also rule out retention here by checking the volume of the bladder post-void. For other investigations, you ask the patient to keep a 3-day bladder diary, do the International Prostate Severity Score to assess how bad the symptoms are, and then consider urodynamics if you want to rule out an overactive bladder. So keeping with the theme of structure, we can split management into initial management, definitive, and long-term management. If the patient is asymptomatic, a bladder diary is enough. But then for patients with symptoms, an alpha blocker like tamsulosin is the first line, before we put them on finasteride, the 5-alpha reductase inhibitor. This is because finasteride can cause a bunch of side effects for a small proportion of patients, like sexual dysfunction. The definitive management for BPH is transurethral resection of the prostate. You can see in that GIF looking through a cystoscope camera how part of the prostate is excised with a bipolar. Previously, surgeons used a monopolar device, which required the use of a hypoosmolar fluid to irrigate the urethra and bladder during surgery. However, this started causing something called TURP syndrome, where patients got symptoms of fluid overload and dilutional hyponatremia. Nowadays, bipolar TURPs are done, which use an isotonic irrigation fluid, and that significantly brought the rates of TURP syndrome down. You have some alternatives to TURP, which are the hole-up laser, which is a bit challenging, prostatectomy, and also prostate artery embolization. And then for long-term management, you can think of things we do for complications of BPH. So for erectile dysfunction, we can consider PDE5 inhibitors. And for severe storage symptoms, we can think of prescribing anticholinergics. And that about sums up everything you need to know about BPH as a med student. Let's quickly run through the first actual malignancy here, so prostate cancer. So definition-wise, it's again caused by the overproduction of cells in the prostate from the influence of DHT. But this time the cells have malignant morphology and the prostate can invade other tissues. Fortunately, 10-year survival is 80%, meaning prognosis is usually good. In terms of pathology, 95% of prostate cancers are adenocarcinomas. The acinar type is more common, whereas the ductal types are more aggressive. In terms of anatomy, most arise in the peripheral zone, where sometimes you have cancers arising in the transitional and central zones too. The picture should help you understand what we're talking about here. So typical presentation. We have similar risk factors to BPH, but add in bodybuilders on anabolic steroids. Prostate cancer can be asymptomatic, or it can cause the same lower urinary tract symptoms that BPH does. But symptoms like bone pain, weight loss, and palpable lymph nodes could mean the disease is more advanced. On examination, again, a DRE is essential, but this time the prostate feels irregular, asymmetrical, and nodular. Our secondary differentials here are BPH and UTI. Red flag differentials to look out for now can be something acute, like prostatitis, or something sinister, like metastasis to other organs. So investigations to work up differentials. We can start off with a history and exam. Like before, do a DRE and also look out for positive risk factors. It's a good idea to also rule out things that might cause a raised PSA, leading to a false positive result like we discussed earlier. Things that can raise PSA include BPH, UTI, recent sex or ejaculation, intense exercise, or other urological procedures. So bedside tests are also the same as before. Urine dip, routine FBC, CRP, UNE, and of course the PSA. Remember that PSA less than 10 is low risk, 10 to 20 is intermediate risk, and 20 plus is high risk for cancer. Sometimes the ratio for free to total PSA is calculated to make the PSA result more accurate. And then for imaging, a multi-parametric MRI is the gold standard. You can see in the images the difference between a normal prostate gland above and one with a prostate tumor below. The MP-MRI also helps us calculate another value, which is the PSA density, by doing PSA divided by prostate volume. A value over 0.14 is considered high risk for prostate cancer. You then have to do a CT chest, abdomen, and pelvis for staging. And then finally, in other tests, you have to take a biopsy of the prostate gland if the imaging results are suspicious. This is done transperineally instead of transrectally these days because it reduces the risk of infection. The biopsy is then sent for something called Gleason grading. I've put in a few more pictures to show how staging and grading works. A tumor in the prostate that's not palpable is T1. T2 is when it becomes palpable. T3 is when the tumor goes through the prostate capsule, which surrounds the gland. And T4 is when it starts invading other pelvic organs. Gleason grading is done by pathology, but it's basically a measure of the proportion of cells in the biopsy that look normal and neatly packed versus the crazy abnormal cells. So the first thing to do to manage prostate cancer is adding the patient to the MDT list. That basically means an MDT meeting will happen where they'll discuss the investigations we've done so far and then group the patient into either low, intermediate, or high-risk groups, which will then dictate the definitive management. If the patient is low risk, all they require is active surveillance. This involves doing a PSA every 3 months, DRE every 6 months, and redoing a biopsy every 1 to 3 years. This allows us to carefully monitor any disease progression. For intermediate to high-risk patients, a radical prostatectomy is required, which removes the prostate alongside the seminal vesicles and lymph nodes in some cases. This can either be done laparoscopically, robotically, or as an open approach. I threw in an animation of the robotic approach there. The main risks of this is erectile dysfunction, which can affect around 80% of patients. Then also stress incontinence and bladder neck stenosis can happen. The alternative to radical prostatectomy is radiotherapy, either with an external beam or via brachytherapy. Finally, if the patient has METs, they require a medical approach with androgen deprivation therapy and chemotherapy combined. The only thing to remember for long-term management is that active surveillance is also done for intermediate risk patients. And that's prostate cancer. Next, we move to bladder cancer. This is a cancer that develops on the lining of the bladder. Over 80% of these are transitional cell carcinomas. Squamous cell carcinoma is less common, and adenocarcinomas and sarcomas are pretty rare. Anatomically, the transitional epithelium, where most of the bladder tumors occur, is the inner lining of the bladder. The connective tissue layer, lamina propria, sits underneath that. Then comes the muscular layer, and finally the fatty tissue layer on the outside of the bladder. Although most bladder tumors are superficial with good prognosis, they're quite persistent and come back about 70% of the time after treatment. In terms of typical presentation, risk factors include age, smoking, working in industrial jobs such as in the rubber or dye industry because of aromatic hydrocarbon exposure, and previous pelvic radiation. Bladder tumors present as painless. Remember, painless hematuria. Patients might also have recurrent UTIs and/or lower urinary tract symptoms, whereas pelvic pain, weight loss, and lethargy all point to more advanced disease. Bladder tumors on examination are pretty unremarkable, so a good history is essential here. Our secondary differentials can be UTI and renal stones. Red flag differentials to look out for are prostate cancer and hydronephrosis. For investigations, like I said, start off with a really good history. And then on the bedside, we're going to dip the urine to rule out UTI, but also send off urine cytology because there's a chance we can find evidence of bladder tumor cells there. Again, we do our routine FBC, UNE, CRP, and also check PSA. For imaging, we're going to do ultrasound of the bladder, CT and/or intravenous urography, and also consider MRI. A combination of these imaging modalities will give us all we need to stage the tumor. But the most important investigation, which should be done for all painless hematuria, is flexible cystoscopy, which, like you see in this picture, allows us to really visualize the lesion close up. If we see something suspicious, we put in a rigid cystoscope, which will allow us to get a biopsy, but the lesion still looks like a tumor. Like most cancers, again, our initial management should be to add the patient to the MDT list, where all the investigations are discussed to come up with the best management plan. If the tumor is not invading the muscular layer, the patient will be managed with a transurethral resection of bladder tumor, or TURBT, using a rigid cystoscope. The specialist will also consider adjuvant intravesicular injections of BCG or mitomycin in this case. For tumors that have invaded the muscular layer and is not responding to TURBT, the specialist will consider removing the bladder entirely, a radical cystectomy, and then creating a urinary diversion with the small bowel in the form of either a urostomy or bladder reconstruction. If the patient has metastatic disease, other chemotherapeutic regimes are given like cisplatin, and we also need NDT plus palliative input to see what the best course of action is for the patient. Since recurrence rates are high for bladder tumors, we need to have regular follow-up and surveillance with cystoscopy and cytology as long-term management. So that's bladder cancer done. We'll do renal cell carcinoma next. This is a renal tumor that you'll likely be asked about, and it's basically an adenocarcinoma coming from the renal cortex, the peripheral bit of the kidney. If we zoom in closer, RCCs usually come from the proximal convoluted tubules and show up on the upper pole of the kidney. Unfortunately, about 25% of RCCs will have METs on presentation. They spread to the renal vein, inferior vena cava, and adrenal gland through direct invasion, and sometimes to the brain, bones, liver, and lungs via lymphatic and hematogenous spread. So typical presentation, smoking and dialysis are your biggest risk factors for RCCs. There's also genetic risk factors like von Hippel-Lindau and BAP1. There's industrial exposure, living in a developed country, as well as hypertension and obesity. The triad for RCCs is hematuria, flank pain, and flank mass, but not every patient commonly presents this way. Like many cancers, you have lethargy and weight loss, but you really want to look out for paraneoplastic syndromes. Three good examples of this are hypercalcemia, since the kidney plays a role in the parathyroid hormone, polycythemia because of erythropoietin, and also hypertension because of renin. On examination, large RCCs will show up as a palpable flank mass, whereas left-sided RCCs can cause a varicocele to develop because it compresses the left testicular vein. Our differentials for this could be UTI and renal stones for secondaries, and for red flags, we're looking out for pyelonephritis, AKI, and bladder cancer. A good history and exam will help rule out differentials, and then at the bedside, a urine dip with cytology is useful, again, just like bladder cancer. Then routine FBC, UNE, CRP. For imaging, an ultrasound of the kidneys, CT abdo and pelvis first before contrast, and then after contrast has to be done. Finally, to look for METs, we're also adding in the head and chest CT. Biopsy is not always done, but can be considered for small masses. I've added a few pictures there to show you how kidney tumors will look like on CT. Also, there's a little guide on staging kidney tumors. Stage 1 is less than 7 centimeters. Stage 2 is over 7 centimeters, but stays in the kidney. Stage 3 is when it starts invading tissues around the kidney, or perinephric tissues. And then stage 4 means that the tumor has metastasized. We'll end this presentation with testicular cancer. Primary testicular tumors are divided into germ cell, the most common, or non-germ cell tumors. Non-germ cell tumors are mostly benign. Germ cell tumors, on the other hand, are classified further into seminomas and non-seminomatous. Seminomas usually stay localized and have good prognosis, whereas non-seminomatous tumors often metastasize. Risk factors for testicular tumors include young males, Caucasian ethnicity, undescended testes, previous history, family history, and also Klinefelter's disease. It'll present as a unilateral, painless testicular lump, whereas if you have systemic symptoms like weight loss, back pain, or dyspnea, it could suggest metastasis. On examination, the lump will be irregular, firm, fixed, and will not transilluminate. For our secondary differentials, we can think of benign masses like hydrocele or epididymal cyst. The red flag to look out for, though, is epididymitis, because it's acute. The best way to work up masses is with a good exam, which can be remembered as 6S and campfire. 6S stands for sight, size, shape, symmetry, skin changes and scars, whereas campfire stands for consistency, attachments, mobility, pulsation, fluctuation, irreducibility, regional lymph nodes, and edges. I know it's a lot, but if you have it memorized once, it's going to stay. And then bedside test we should do is check for 3 important tumor markers that can catch testicular cancer. This is beta-HCG, alpha-fetoprotein, and lactate dehydrogenase. They're not ultra-sensitive markers, but it's good to include them alongside your routine tests. Now for imaging, a scrotal ultrasound is good. You can see the difference between a normal and abnormal testes there in the picture. Staging is done with a full CT, chest, abdo, pelvis, just to check for METs. And then the way you stage testicular cancer is using the Royal Marsden staging system. This says that stage 1 tumors stay in the testes, stage 2 tumors go up to the lymph nodes that are below the diaphragm, stage 3 tumors are found in lymph nodes above and below the diaphragm, and then stage 4 means it's metastasized outside the lymph nodes. Other tests you should consider is a fertility assessment in patients who plan to have a family in the future, because the effects of chemo and radiotherapy can negatively affect fertility. There are also some specific indications to do a biopsy of the other unaffected testicle, which should be discussed with a specialist. So like before, we start management by adding the patient to the MDT. Examiners love hearing that word. Definitive management for localized renal tumors is either partial or radical nephrectomy based on the size. You can see how it might look like on that picture. Surgeons will usually try their best to save the adrenal gland as well, if possible. The alternative here is either percutaneous ablation, where you burn the tumor, or lap/percutaneous cryotherapy, where you freeze it. Renal artery embolization is also considered like if hemorrhage is present. For metastatic disease, we need to combine nephrectomy with immunotherapy and biologic agents. Remember, these are not classified as chemotherapy because standard chemo doesn't work as well on RCCs. Surgeons will also try to resect any mets if possible in this case. Finally, for long-term management, we can consider surveillance for small, slow-growing masses if the patient has limited life expectancy. Finally, we move on to management, and again, start by adding the patient to the MDT list. For low-risk tumors, resecting the testicle, epididymis, spermatic fascia, and cord via radical orchidectomy is the best, and this is done by the inguinal approach these days because it limits lymphatic disruption. For high-risk patients, usually adjuvant chemotherapy is also added, and then in metastatic patients, you go for a combination of chemotherapy and radiotherapy based on the MDT input. In terms of long-term management, patients will require regular surveillance with a CT, chest X-ray, and tumor markers after treatment about twice a year. Also, since chemo has a risk of causing leukemia in some patients, it is also good to monitor their blood counts too. And that concludes the presentation. I've put in a few MCQs for you to attempt based on what was explained here, and I've also attached a PDF with all the slides so you can refer back to them if you need. Thank you so much for your time. Hope this helped.